Great. Thank you, Dr. Adalja, for joining us today. We really appreciate your time. As you can imagine, we received a lot of questions from employees, so I'm hoping we'll be able to get to as many of them as we can. So what I'd like to do is maybe we could just start off by you talking to us a little bit about what we've learned since March with the coronavirus. What are your thoughts on COVID-related statistics regarding transmission and mortality reported by state agencies and government officials? Maybe you could just tell us a little about what sources you think maybe are most reliable or ones that we should avoid following.
So it's very hard to get good statistics, and it's because there's still a lot we're learning, and a lot is dependent on testing, and testing is very different around the globe. So when you look at case fatality ratios, when you look at the number of cases, what percent get hospitalized, it's very hard to get a really good picture. So often people in the field look at the official state statistics by the CDC or the WHO and kind of look at them with kind of a correction factor, knowing that they're likely underestimating the number of infections. And if they're underestimating the number of infections, that means they're overestimating the case fatality ratio and the hospitalization ratio. But we've learned that in my mind, I think that the infection fatality ratio is if you get infected, the chance of death is probably around 0.5% on average. That's my kind of best estimate of where this sits. You're going to see bigger numbers, but that has to do with the fact that we're not testing as much as we need to be. And I think the hospitalization rate is probably closer to 5%. And what I think is it's going to be very difficult as we go along, and we're only going to know in the retrospect what the actual numbers are. But we're learning a lot about this disease. We know it's more severe than seasonal influenza. We know it's going to be something that exacts a major toll on us, and it is something that we will constantly be learning about day to day as we get through this pandemic.
So along the lines of what we learned and some recent events, as more data becomes available each day, can you share what you know about multisystem inflammatory syndrome in children and how children are responding to treatments?
So multisystem inflammatory syndrome seems to be a rare complication of children that's related to the coronavirus. We don't quite understand the causal mechanism yet. We know that many of these kids had the coronavirus either by antibody testing or by PCR testing, and they for whatever reason, developed this autoimmune phenomenon. It's very similar to Kawasaki syndrome, but has some differences. It's usually in older kids, and lots of GI symptoms, meaning abdominal pain, diarrhea, those types of symptoms predominate. And it does tend to do, kids who get it still tend to do okay with it. There have been some fatalities. It is extremely rare, and it's not the usual course of disease with children. Trying to understand whether steroids may work or not, there is an active research program going on. And it's interesting because we saw it in certain countries and didn't see it in other countries, and we don't quite know what the answer to that might be. It might be that it was underappreciated or not reported, or the testing of children wasn't very robust at that time, but it is something we're going to hear a lot more about as we go forward in this pandemic.
Right, I can imagine. We received a lot of questions related to transmission. So there's a lot of information in the news, which sometimes feels like it contradicts prior information about whether the virus really lives on surfaces and can be easily transmitted that way. In your opinion, what scenarios are the highest risk for transmission? Should individuals be really concerned about the virus living on surfaces, wiping down groceries, packages? What about flushing toilets or even like hotter temperatures? I know that was a lot, but maybe you could just kind of give your thoughts on transmission in general.
Transmission is most likely to occur with close contact with an individual that's symptomatic, meaning has a fever, is coughing, has a sore throat. That's where we see most transmission occurring, and it's really clustered in households. So that tells you that prolonged contact is usually necessary. The virus can be viable on surfaces, but surfaces are a secondary mechanism of transmission. The main way people get this is from other people, touching them, being in contact with them. Surfaces do play a role, but it's much less important. And I myself have not washed groceries any different way. I've not changed the way I flush the toilet. All of those are kind of theoretical risks, but they're not the main way that people are getting this. It is true that surface temperatures, so it's on a surface, the temperature, the UV exposure, the humidity do influence how long something remains viable. And that's why we see seasonality in many respiratory viruses, because as it gets hotter, as it gets sunnier, as it gets more humid, surface transmission decreases, and that adds to the seasonality of a virus.
So what are your thoughts on the recent statement by the World Health Organization that seems to imply that asymptomatic spread of coronavirus is very rare?
So this is a controversial statement, and it's a little bit confusing, but what what it really means is that we were trying to understand what proportion of transmission comes from people who get infected but never ever have any symptoms. And it appears that that's actually rare. But that doesn't exclude the fact that there are people who get infected, may not have symptoms today, but might get them tomorrow, who are still contagious. And I think we have to tease apart what's called pre-symptomatic transmission from asymptomatic transmission. And we know that this is occurring. We want to know more about what circumstances it occurs. Is it just households? Is it intimate contact? Is it people who are sharing utensils? Because that really influences a lot of our public policy in terms of mask wearing, for example. That's premised on the fact that there is pre-symptomatic transmission ongoing and that masks work as source control. So this is an important question. What the WHO said over the last 2 days shouldn't change your behavior. You should still be doing the same stuff that you're doing currently. And this is something that's kind of an internal epidemiological debate over pre-symptomatic versus asymptomatic transmission. It has really little to do right now with what we're recommending to the public.
So you just mentioned something about mask wearing. We also received a lot of questions on that. So one of them was, how safe is it if I'm in contact with someone who's not wearing a mask, even though I'm wearing one myself?
You have to remember that your mask wearing is not to protect you from getting infected. It's to prevent others from being infected by you. So it's really the other way around. It's your mask protects other people and their mask protects you. So if you're around somebody without a mask, it's probably not that much of a problem for you as the mask wearer. It's their perspective that you have to think about. Are you one of those people that's pre-symptomatic that could have infected them? And that's what you'd have to think about. So it's less about, it's a little bit of a complicated situation with the masks, but just remember that it's about decreasing source control from pre-symptomatic spreaders, not preventing you from getting infected.
And so along those lines, if you can't maintain the 6-foot social distancing and the person near you isn't wearing a mask, what are some of the other things that we could be doing to reduce our risks?
When you're within 6 feet of a person, you need to wash your hands a lot. You need to refrain from touching your face, refrain from touching common surfaces. And the people that you're around, as long as, I think for most casual contact, it's not necessarily going to always result in a transmission event. It's prolonged contact. Maybe if they're not talking or if they're not doing things that cause droplets to come out of their mouth or their nose, it's unlikely that there's a transmission mechanism. You have to remember the virus can't teleport. Even if you're 6 feet within a person, you need to have a mechanism for the virus to get to you. So it has to be talking, singing, shouting, all of those types of things would cause that to happen. It's not just transmitted by somebody walking past somebody within 6 feet of them without a mask.
Got it. So let's transition to talking about vaccine. What is the likelihood a vaccine will be developed and deployed by the end of the year? And which country do you think will be the first to come out with a vaccine? And do you think that country will vaccinate their own first? And is that the right thing to do?
Within the end of the year, having a vaccine is a really daunting challenge. Vaccine development is something that's usually measured in years, not in months. So it would be in the realm of possibility, but be very daunting. And they are doing things a lot faster this time with this vaccine development project, with using technology that didn't exist even 10 years ago. So it's in the realm of possibilities, but I wouldn't wed myself to a date by the end of the year. I do think that we've got multiple countries with products that are really moving through clinical trials pretty quickly, the United States, the United Kingdom, and China, namely. I think if I had to pick, I think that China will probably be the first to make a vaccine. And I do think countries will vaccinate their own first before they export it to other places. We saw that during the 2009 H1N1 influenza pandemic, where Australia made the first pandemic vaccine, but did not export that vaccine until their population was vaccinated. I don't think it's the best way to do it. I think what should happen is that the high-risk individuals and healthcare workers of the world should be vaccinated first and then move to other parts of the population. But unfortunately, I think that probably will not happen.
Right, that makes sense. What are your thoughts on the efficacy of such a vaccine? And is there a possibility that the virus continues to mutate, which would prevent the vaccine from protecting us against the disease?
To me, there's no biological block to make coronavirus vaccine. We don't have a human coronavirus vaccine, but we do have coronavirus vaccines for cows and for bird species that have been pretty successful. So biologically speaking, other animal species can be vaccinated against coronavirus successfully. So I think that we will be able to as well. The coronavirus does mutate, but it mutates much less than other viruses. And again, going back to the veterinary world, we haven't seen that those coronaviruses mutating away from the vaccine strain. So I do think that this is something that we likely can do, and it will be a lot more durable than, for example, the flu vaccine, because coronaviruses just are a different family of viruses and don't mutate in the way. So maybe this will be more like our measles vaccine.
And when the vaccine is ready, should we wait and see what the side effects are? Or, for instance, like, would you get the vaccine right away?
I would get the vaccine right away. There will be phase 2 and phase 3 clinical studies that are going on that will have some way of gauging what the safety data is. We already have some safety data on some of the phase 1 clinical trials. So we will know what the risk profile is. And I do think that it's important to remember that even though this is going fast, we will be still doing the same safety trials. And there is a high threshold for a vaccine because you're putting it into healthy people. So they really have to be safe. And especially if you think about 8 billion people in the world being vaccinated, something that occurs only in a small percentage of people will end up being a big number if you vaccinate the world.
So moving on to the topic of testing, what are your thoughts on COVID and or antibody testing being a requirement to return to work or to return to school while we await the release of a vaccine?
I don't think that you can really operationalize that in a way that makes sense. Remember that a COVID PCR test is only one moment in time. So how frequently are you going to do it? How are you going to compete with resources from hospitals? We really, I don't think, can operationalize it. I don't necessarily think it makes sense. The Infectious Disease Society of America guidelines don't recommend doing routine testing of people that don't have symptoms unless they're part of an epidemiological cluster or contact investigation, or if they're going in for surgery or some kind of procedure and the hospitals requiring it. We are thinking about using this type of testing for certain workplaces, namely those of professional athletes. So we're hearing about soccer players getting tested twice per week in Germany, and many of the NCAA schools are thinking about ways to do testing for some of their high-risk sports. But I don't think that for the average person it makes sense to do that, because you'd have to come up with some kind of frequency. We don't really know what that frequency would be, and it's no guarantee that you're not going to get exposures. Antibody tests, on the other hand, are a little bit different. We know that they probably do reflect the fact that people have been infected and have some protection from being reinfected for some period of time. We don't know how long that is. We don't know what level of antibodies are required for protection. And there are many kits out there that are very poorly specific, meaning they have a lot of false positives. So you have to be sure that you're actually getting tested by a valid test kit. But I still think that there's not enough data to operationalize it. I think many workplaces will go back to work without that testing in place, but have robust plans about how to deal with potential cases, exposures, how to work with their health departments. I think there's other measures that you can put in place to make your workplace safer than it was prior to the pandemic.
Absolutely. And I think we're following that protocol as well. Moving on to talk about a little bit about the second wave. So what are your thoughts about this second wave that we're all hearing that could likely occur in the fall or the winter? What steps would need to be taken at that time? Are we prepared to adequately handle a second wave? Maybe you could speak a little to that.
So I do think that this virus is going to be with us until there's a vaccine. And we know that coronaviruses, remember this is the 7th human coronavirus we've discovered, have seasonality. And they tend to accelerate transmission in colder months and temperate climates. So we do have to be prepared for intensification of transmission as we get into respiratory virus season. The fact is that we may not fully suppress in the summer because there's so many cases still occurring in the United States, for example, right now, 20,000 or so per day. So we may not have a very distinct trough before there's another peak. So it may be that we have a low level of transmission and then it peaks up a little bit, but not necessarily as sharp as we see with influenza or the other coronaviruses. We do have to think about hospital capacity in the winter because remember, influenza will also be there as well. That's why it's really important that people get flu vaccines to keep themselves out of the hospital for influenza so we can deal with the coronavirus cases that we're going to have. I do think that we have to make sure our diagnostic testing, our personal protective equipment, all of that is in line as we go into the fall. I don't think that we'll see any kind of really economic shutdowns again. I think it will be much more targeted and precision guided, hopefully, because we're in a much, much better place now, even in June of 2020 than we were in March of 2020. And we'll be able to handle those cases most likely in most parts of the country. And we know much more about how to treat patients with this. So hopefully we'll be able to keep it down to a minimum of disruption. But we do have to prepare for intensification of spread in the fall.
So moving on to commuting. So what are your thoughts on riding the subway? How can we best protect ourselves? What about if employees have an even longer commute that consists of a few different methods, whether it's train, subway, bus? Should they be doing anything different?
So you have to remember that in the era of the pandemic, no activity is going to be without risk. So this is going to be something that you have to incorporate into your risk profile every day you step outside of the house. And when you think about public transportation, there are going to be opportunities for the virus to spread because there's lots of people in contact with each other, lots of common touch surfaces, and sometimes you're very cramped on subway cars. So it's going to be very difficult to come up with a way to completely eliminate the risk. But you could do things like, for example, making sure that you're trying to stay 6 feet away from people, washing your hands a lot, refraining from touching your face. All of that will help. If there's a crowded subway car, maybe you skip that subway. Or maybe you walk a couple blocks instead of taking the subway. There's ways to minimize that risk, but it's not going to be a zero risk. And it's really going to depend on each person's risk tolerance and how much they're willing to expose themselves to the virus, because it's going to be with us. And they're not easy black or white answers I can give people. It's all going to be shades of gray depending upon their own risk tolerance.
Yeah, absolutely. So these next set of questions, we're kind of classifying it into the is it safe to? Because as you can imagine, received a lot of questions about people's personal environment. So is it safe to get together with people as long as you're social distancing? What about, can I hug my grandmother and other family members who don't live with me? I want to meet my niece who was born in February. I want my parents to come over and visit. And can we have lunch outside? Is it possible to now start going out to restaurants with outdoor seating?
So this is, again, something that there's not going to be black or white answers for. It's all going to be a person's risk tolerance. Remember, enforced social distancing was about preserving hospital capacity. It didn't mean the virus is going to go away. Now it really falls on individuals to decide which things are essential to them, what values they want to pursue, which they don't want to pursue. And I can say that all of those activities can be relatively safe, but no activity is going to eliminate the risk of transmission. But I would say if these things are important to you, to go see your niece, there's ways to do it that are safe. Make sure you wash your hands a lot. Make sure that you're not sick when you go see that person, and really just engage in the activity and knowing that there's going to be a risk. So I'm sitting in Pittsburgh right now, and the restaurants are open, and I was just in a restaurant for lunch. It's not. And they have indoor seating in some of these places with reduced capacity. So it really has to do with your risk tolerance. So all of these people, lots of times I get questions, is it safe, is it not safe to do that? And it all boils down to, all I can do is give you pointers on where the risk is and how to reduce the harm. And then it's really going to fall to you. It's kind of not something I can proscribe because the virus is there. And people are going to go about and take actions and pursue values and engage in activities that are important to them. And I think it's not right to dogmatically try to apply social distancing to every situation, because it really is going to be an individual decision. And hopefully that's guided by some of the evidence and each individual's risk tolerance, as well as their risk profile for severe disease and who they're in contact with. Maybe they take care of an elderly person or something that might make them be a little bit more mindful. But it's really not one size fits all.
Yeah, absolutely. And on the same vein, what about day camps? A lot of people asking about, should I send my child to day camp? And if they have to travel on a bus, what are your thoughts there?
You know that their day camps are trying to make their operations as safe as possible. There's always going to be a risk there. Day camps tend to be outdoors, and and we see transmission is much less likely to happen outdoors versus indoors. So I do think this is something that's relatively safe. Obviously, you have to look at your own child's risk profile for severe disease and think about what the virus would mean if they were infected with it, if they brought it home. But I do think that day camps are relatively safe and can be attended. And I would encourage people to look at them and think about them. I don't think, again, you have to remember that this virus isn't going anywhere. So we've got to find a way to live with it. And I don't think the solution is to completely put your life on hold until there is a vaccine. I think we have to find a way to do this in a way that reduces the harm from the virus, but at the same time allows people to get back to their lives. And it's not easy, and it's, like I said, very different for each person. But I do think that many of these activities can be done safely.
And the final question in this category, is it safe to go for a run without a mask? And if I'm running on off-peak hours in an area that's less populated? It sounds like you pretty much already answered that in some other ways, but I don't know if there's anything specifically for someone who's going for a run and is obviously breathing a little bit more heavily.
I do think it's safe for you to go running without a mask. Obviously, if you're going to be around other people, you have to be careful and mindful of that. But most people who are running only have transient contact with other individuals. And I think that that's a relatively safe activity that can be done without a mask.
Okay. So moving on to blood types. So there are reports that some say that certain blood types may have some protection from becoming infected. And yet other articles say that there are certain blood types that you would have more serious complications if you were infected. Can you talk a little bit about this?
So this is preliminary data coming out on blood types, and we know that blood types are a genetic biomarker that really represent a whole host of different genetic changes. And we have seen other infectious diseases where certain blood types are more likely to either have the disease or not have the disease. And what we're seeing right now is that people with type O blood, like I have type O blood, are less likely to be infected or have severe disease, whereas people with type A blood may have more severe disease. Again, this is preliminary, but it does fit with what we know, that there is a genetic susceptibility to infectious diseases, and it varies for each disease, and it's not necessarily something that we've worked out completely, and it will be something we have to study in much further detail, but there is suggestive data that's already coming out about the difference in blood type and susceptibility.
Interesting. What about certain underlying medical conditions? So, for example, heart conditions, I think we've all heard can put people at higher risk for severe illness if they get, COVID-19. But if someone has high blood pressure or a heart condition or anything, and they're managing well with regular medication, is that person still at higher risk? And I guess the same question could be applied to high cholesterol, diabetes, Crohn's, other conditions.
So when it comes to the coronavirus, it is definitely clear that the more risk factors one has, the more likely you are to end up hospitalized, severely ill, or dead. And hypertension is one of those that's come out very strongly in these studies. And it does look like hypertension maybe doubles your risk of death. And that's even including treated hypertension. So it's just the actual fact that you have hypertension rather than whether or not it's controlled. The same is likely true of diabetes. High cholesterol in itself, I'm unsure if that's actually going to pan out as a risk factor. Crohn's disease, if a person is on, for example, an immunosuppressing medication like an injectable or a steroid, that will increase your susceptibility. But really, it's high blood pressure, obesity, diabetes, lung disease, any immunosuppressing condition, obesity. That's where we're seeing clustering of severe cases.
Okay, so moving on to the reopening of the economy. Across the U.S., we're now seeing states in various stages of reopening daily life. What is your take on letting businesses open up and lifting the stay-at-home orders, and what are your recommendations?
So it's important to remember, as I said earlier, that social distancing was enforced solely to really keep hospital capacity preserved, making sure that the number of cases that we had never exceeded hospital capacity, not to get cases down to zero, just to have them occurring at a clip that was manageable by hospitals and health department contact tracing teams. So now as businesses open up, it's going to be important to keep an eye on hospital capacity. And we're already worried about a couple of places like Montgomery, Alabama, the Twin Cities prior to the protests, and Arizona as well. And I think that's going to be the key. We know that any kind of social interaction and social mobility is going to increase the number of cases. That's a simple biological fact. It's about keeping the cases to a manageable level. So as you see states open up, they have to keep an eye on hospital capacity and make recommendations to their public based on what's going on in the hospitals. If hospital capacity is okay, things can continue to proceed. But if hospital capacity starts to get compromised, you may see them recommend other types of certain activities be curtailed because of that. You have to remember also that there is a balance between letting the virus spread rampantly and having economy open up. And I think the word economy is kind of a bad way to put it. It's really people's livelihoods. And in the end, the economy is people's lives. So we know that an economic shutdown for a long period of time is going to result in increased unemployment, increased deaths from other diseases. We know that people already were delaying chemotherapy, delaying cancer screenings. Vaccinations went down, I think, about 80% during the height of the shutdowns in the United States. So there are consequences, and those consequences increase over time. So we really have to find some kind of way to live with this virus and have this kind of middle, move away from false alternatives or politicized alternatives and try and find a way to actually move forward with this virus that we're kind of stuck with for some time.
So speaking of moving forward, what are your thoughts on about New York City schools opening in the fall? Should they open, and how can they do it safely?
I was one of the individuals who wasn't necessarily in favor of blanket school closures. We don't know that a lot of the rationale behind the school closures had to do with extrapolating from influenza. With influenza, we know that children are magnifiers of infection and that there is some data that school closures may be able to flatten the curve. That's not the same thing for coronavirus. It's two different viruses. And we know children get infected. We know they get viral loads in their nose. We know they have a lot of contacts, but do they actually drive epidemics? And there hasn't been a lot of data showing that they drive epidemics. And many places did not close schools. And remember, during this whole time, daycare centers were open for essential workers. And we haven't heard much about outbreaks at daycare centers. So I do think schools are something that can be done, and we should do them, because there are lots of negative consequences to closing a school in terms of many children rely on the school for their breakfast and lunch. We know that distance learning is failing. We know that this magnifies some of the societal grades that we have, meaning that the lower socioeconomic groups that may not necessarily have high-speed internet, may not have iPads, and those school districts are not equipped to do it versus private schools that can do it. So this is kind of making that worse. And I think that you have to think about the fact that in the fall, kids are going to be congregating outside of school together. It's not going to be like we have a stay-at-home order. So if kids are congregating outside of school, how will you prevent them from transmit if that's what your worry is, of keeping them from congregating? And remember that in order to get the economy running, in order to get people back to their livelihoods, people need to deal with childcare issues, and schools do serve that purpose. So there's a lot of reasons that schools should open, and I think there's not any good data supporting their closure.
Yeah, really, really good point. And I'm sure, many of our employees are interested in that. So the final category that we have is, talking about the future. This is actually a question about our custom, about the handshake in business culture. Do you think we should abandon this custom, or do you think one day we'll go back to shaking hands again?
I do think we'll go back to shaking hands again. And you can shake hands now. Just wash your hands afterwards. I mean, it's very simple. It's just if you're going to shake hands, then have a squirt of the hand sanitizer afterwards. I don't think we necessarily have to abandon everything that's human about us because of this virus. I think we just have to find a way to reduce the harm from the virus with a lot of common sense measures.
Makes sense. What do you think the world will look like in 2 years? Will we eventually go back to life as we knew pre-March, or do you think there will be another coronavirus? What are your thoughts on our new normal?
So the new normal is not going to be the same, even when we have a vaccine, because there were trends going on that have been really accelerated by this virus. And this is true of any pandemic. The Black Death did this, 1918 did it, they changed society. So we're doing this by Zoom. I think that's going to become much more common, that people are going to do less traveling and do much more virtually. People who are on the fence about online shopping are probably now been pushed into that. Ordering everything online, streaming services for entertainment, those are becoming much more popular. People may not want to go back to movie theaters so much. People's vacations, where they travel, all of that's going to be a lot different in the future because things that were happening, shopping malls, people were going less to them. Now shopping malls are closing, department stores are closing, and those trends are being accelerated. So I think that you're going to see more and more of that happen, and we will be living in a different world because the pandemic is going to change us and accelerate trends that were already going on. I do think we will be at risk for other pandemics, hopefully not another coronavirus, because hopefully we'll take the coronavirus off the table with vaccines and antivirals that will be developed. But there always are going to be threats from pandemic viruses. This planet is dominated by microorganisms, and we're just a very small portion of the biomass of this planet. So we are always going to be threatened by infectious diseases.
So last question. As states and cities begin their phased reopening, what do you think is the single most important thing that must be done to ensure the safety of our communities?
The single most important thing that must be done is that you need to reiterate to the general population the virus isn't there, that social distancing enforcement was about hospital capacity. Now that that's being lifted, that means that they have a bed for you if you get sick. It doesn't mean that the virus is gone. So you cannot behave as if the virus isn't there. And what actions you take are going to dictate how much exposure risk you have. And it's going to be, and those actions are going to be different for everybody else, but you can't believe that the virus is not there anymore, or that you're not at risk for getting it or transmitting it to other people. So you still have to now exercise individual responsibility, and the virus is going to be with us. So this is something that we're going to have to get adjusted to, and it's going to be difficult for people.
Dr. Adalja, I don't know if you have any positive words to leave us with.
Well, I do think that this pandemic, unfortunately, has galvanized the world to take pandemic threats seriously. Pandemic threats are often neglected and go through these series of panic and neglect after anthrax, after H1N1, and Zika, and Ebola, and bird flu. All of these things come and go. They recede from the headlines and people forget about them. But now I think there is this window of opportunity to fortify our pandemic preparedness, to get it right so this doesn't happen to us again.
Great. Great. Well, thank you very much, Dr. Adalja, for joining us. We really appreciate your time, and it was very valuable information. Thank you.
Thanks.